very good afternoon. Once again, KMI Taman Desa Medical Center is organizing a virtual CME program on DocQuity. A very good afternoon to our speakers today, Dr. Irshath Ibrahim Ali, the hosting team from DocQuity, very well appreciated, as well as the participants. I do see a number of doctors has already engaged. Without much ado, let me have a brief introductions about our speakers today. Dr. Irshath Ibrahim graduated with Doctor of Medicine from University Science Malaysia and further obtained his postgraduate medicine diploma in the UK. He further obtained an advanced master in dermatology from University Kebangsaan Malaysia, and he also obtained a diploma in aesthetic medicine recently. He is currently practicing as consultant dermatologist in the dermatology department in Sultanah Bahia Hospital Alostar, and he's also a visiting dermatologist in our hospitals, KMI Taman Desa Medical Center, since last year. He is a member of Dermatology Society Malaysia, and he also a former honorary lecturer for AIMS University Malaysia, as well as College University Isania Sungai Petani. So without much ado, Doctor, the floor is yours.
Thank you very much, Ms. To. Good afternoon, everyone. So can you see my slides, Ms. To?
Yes, I can see.
All right, okay. So I'll just get right to it. So today I'm going to be talking about fungal infections involving the skin, hair, and nail. It's impossible to cover everything, so I'll just go through the common diseases that you come across in general practice. Okay, so this will be the outline of my presentation today. I'm going to talk about superficial mycosis, the dermatophytes, talk about pityriasis versicolor, candidiasis, a bit about id reaction, contraindications in pregnancy. I'll talk about nail infection. I'll talk about hair infection, PIDRA, and for subcutaneous mycosis, I will talk about sporotrichosis. So first, just a brief introduction about mycosis. So there are three forms. There's superficial, which only infiltrates the stratum corneum. That's the first layer of epidermis. And the subcutaneous will infiltrate deeper into the dermis and subcutaneous tissue. And then there's the deeper or systemic, which spreads through the bloodstream and quite common in patients who are immunocompromised. So this is a diagram of how our skin looks like. So superficial mycosis will affect the epidermis, as you can see in this diagram very clearly, and subcutaneous will affect dermis and subcutaneous tissue. And the last one is systemic mycosis, which will enter our bloodstream and cause a more disseminated and widespread fungal infection. So first off, superficial mycosis. There are three main types that can infect our skin, hair, or nail. So they are the dermatophytes, which are quite common: Mycosporum, Trichophyton, Epidermophyton, and then the moles like Aspergillus, Neocytilidium, Spocularapsis, and then the yeasts, and the most common ones we come across in our practice, like Candida and Malassezia. PIDRA, which is a fungal infection of the scalp, of the hair, is also a yeast. So dermatophytosis, or tinea or ringworm. Now, dermatophytes, loosely translated in Latin, derma means skin, phyton means plants. So they are keratin loving, meaning that they will infiltrate the keratin layer, keratinophilic. So no living tissue is invaded, since the keratin stratum corneum is only the keratinized stratum corneum is colonized. So there's no living tissue here. So it only invades fully keratinized tissue. This is the skin, the hair, and the nails. So there are three anamorphic genera. There's a Microsporum, which typically infects the skin and hair. Epidermophyton, which infects the skin and nails, and Trichophyton, which infects the skin, hair, and nails. Then, depending on the place of origin, the dermatophytes may arise either as zoophilic, that means originate from animals, and then it can infect humans. Zoophilic, it originates from the soil, and then it can infect humans. It's typical in patients who come in contact with soil, like gardeners, for example. And anthropophilic dermatophytes, which grow only on human skin, hair, or nails. So the zoophilic and geophilic dermatophytes elicit only a brisk inflammatory response, but the anthrophilic fungi usually invokes a more severe inflammatory response. So the mode of transmission is from person-to-person contact or contact with shedded skin cells or hair clippings, which may be found in communal showers or people sharing hats, for example. So these are types of dermatophytosis. So according to their affected areas, capitis, corporis, cruris, angum, barbae, manium, pedis, and facialis. So I'll first start with Tinea corporis. So the common dermatophytes that infect or involved in Tinea corporis are the Trichophyton rubrum, mentabrophytes, Microspore mecanis, Trichophyton tonsurans, and if there's follicular involvement, rubrum and verrucosum. And Tinea imbricata is a very unique configuration, which I'll show you some pictures later. It's caused by Trichophyton concentricum. So this is Tinea corporis. So you can see it looks like a map. So the borders are very well defined. It's scaly, it's sharply marginated, can present as plaques, and the enlargement is usually from the peripheral. They call it peripheral enlargement. It will expand on the periphery. There's central clearing, and it produces an annular configuration, round, concentric rings, and arcuate lesions. Arcuate means arc type of configuration. So these are the many presentations of Tinea corporis. Okay, so if you come across Tinea corporis, take for example these pictures here. Could you be dealing with Tinea corporis, or could you be dealing with something else? What could be your possible differential diagnosis? Okay, but you see this first patient here, there's also annular plaques, which are scaly, lack of central clearing. So is this really Tinea corporis, or are we dealing with something else? So if you have to make a differential diagnosis, mycosis fungoides is a differential diagnosis where it presents with patch plaques, which are scaly, and it usually affects almost the entire body, including sun-protected areas like the buttocks, the posterior thighs. And what about this one? Also not too annular, but the plaques are between well and ill-defined. You can see the margins quite clearly. So this is also mycosis fungoides. And what about this one here? You can see this erythematous angry border with central clearing, just like Tinea corporis. But it looks a bit like saucer shape, a bit like saucer shape annular configuration. And the clue is that if you detect sensation, it will be diminished or totally lost. And you will have to examine all the nerves from top to bottom. So what are we dealing with? Obviously, this is leprosy. And this is also leprosy. So this is kind of some of the differential diagnosis that you need to consider when you're dealing with Tinea corporis. Okay, other differential diagnosis like granuloma annulare. So this is it's a reactive form of rash. It can be due to infections like HIV or autoimmune diseases like thyroiditis, diabetes. It might be also associated with lymphoma. So you get this annular plaques, which is quite thick around the border, usually on the dorsum or the hand or wrist. This is also a form of granuloma annulare. It's called perforating granuloma. It looks very much like tinea, does it not? And the other one is erythema annulare centrifugum, also a differential diagnosis to consider. You can see there's a trailing scale. Trailing scale means the scale is trailing on the inside of the rash. Okay, and this is also can be due to drugs, infection, malignancy, and maybe you've seen erythema migrans before, which is due to Lyme disease. It is due to this tick, Borrelia burgdorferi tick, that bites and then causes a localized reaction. So it gives like a configurate erythema. So some differential diagnosis for corporis. And this is Tinea imbricata, which I showed a picture mentioned earlier. So it has this very beautiful configuration. It looks like a woody grain configuration. You know, when you cut a tree, then you see the grain-like morphology. So this is due to Trichophyton concentricum, and quite closely related to, that looks like Tinea imbricata, is Erythema gyratum repens. is another differential diagnosis for tinea corporis. So also the typical woody grain appearance, So this one is almost always associated with malignancy, such as lung CA, other carcinomas like gastric adenocarcinoma, colorectal carcinoma, nasopharyngeal CA, breast CA. So if you see something like this, think about malignancy. Okay, so other differential diagnosis for tinea corporis that are quite common: nummular eczema, which is discoid eczema, psoriasis, pityriasis versicolor, subcutaneous lupus erythematosus, even candidiasis can sometimes be mistaken for corporis. Then I showed a picture earlier of mycosis fungoides, and the other one that may resemble for tinea corporis is pityriasis rosea. So there are a few variants of tinea corporis. The first one I'm going to go through is nodular perifolliculitis, which is due to the same dermatophyte, Trichophyton rubrum. This usually tends to occur in women who, or maybe not just women, though anyone who shaves their legs, then they can, which is quite common in women, then they tend to develop folliculitis, such as this. So this folliculitis is not bacterial; it is due to fungal Trichophyton. So the nodular perifolliculitis that develops is typically due to untreated tinea pedis or untreated onychomycosis that is left too long or not treated adequately. Patients are immunosuppressed or tropical climates. So you tend to get all this, sometimes you get extensive vegetating lesions or granulomatous lesions. So that's why it is known as Majocchi granuloma, nodular perifolliculitis. So the perifollicular inflammation and follicular pustules, which you can see, there are pustules originating from the follicles on the leg due to this dermatophyte. And then over here, you can see the almost papules have a granulomatous appearance. So this is one of the variants. The other variant of tinea corporis is tinea profunda. Tinea profunda is an excessive inflammatory response due to the dermatophyte, and it is analogous to carrion. Carrion I will show you later. In tinea capitis. So when the term profunda is used, it has a lot of synonyms. Tinea capitis profunda, Trichophytia profunda capitis, carrion celsi. So it is closely resembles carrion, where it is become granulomatous, verrucous in appearance, very tender, boggy, erythematous. There are pustules, crusting. Alopecia can be permanent, and there might be regional lymphadenopathy. And tinea imbricata, which I showed earlier, due to Trichophyton concentricum. It's the same pictures. It's quite common in countries like in the South Pacific of Asia, Central and South America, where you get this very beautiful concentric annular rings. It looks like Garitum repens. I showed you those pictures side by side earlier. Okay, so the next one is tinea incognito or incognita. So this is when a fungal infection, when the clinical appearance has been altered. It is otherwise known as a steroid-modified tinea. So the original infection, it looks like it has subsided because post-inflammatory hyperpigmentation has developed, but it is actually slowly extending and may mimic other skin disorders. So topical steroids are not the only cause. Even tacrolimus or pimecrolimus, your calcineurin inhibitors, can also cause tinea incognito, and not to mention systemic steroids. So the clinical features, it is less raised. The margins are less raised. In tinea, you have elevated angry red borders. So this one is less raised margins. Take a look here. And then it is less scaly, but it's more pustular. I don't know if you can appreciate some pustules here. But it's more irritable, more extensive and more irritable. And you might even see some complications of steroid, topical steroid, like atrophy, purpura, or telangiectasia. Okay, so next up is tinea pedis and venom. So it's due to the same organisms, same dermatophytes, rubrum, mentoprophytes, epidermophyton floccosum. Transmission is either from contact with an infected person, anthropophilic, zoophilic, and zoophilic, or auto-inoculation. The risk factors are occlusive footwear, communal bath, shower, or pool. So tinea pedis, there are 4 types. The first type I'm going to go through is the interdigital type. The interdigital type, it can either be dry, which you can see here. This is a very common condition that we come across our clinical practice, including general practice. And this is tinea pedis when it is become macerated. You can see it's more moist. Okay, so the typical distribution is at the distal aspect of the feet, affecting a few toes or all the toes altogether. Then the next type is the tinea pedis bullous type, where you develop blisters. This is over the plantar aspect. And then the third type is tinea pedis moccasin. Moccasin tends to follow the distribution of your shoe. It's the shoe pattern. So it's coined as moccasin type. So both legs are affected. And the last type is the acute ulcerative type. So this one is a zoophilic. The typical dermatophyte is interdigitale, and sometimes it can be associated with superinfection with other gram-negative organisms. So can result in ulcer, vesicle, pustules, purulent ulcers on the plantar surface. Okay. So when certain fungal infections like tinea pedis and carrion, for example, can be associated with dermatophytic reaction or EAD reaction. EAD reaction goes by other names as well, autosensitization dermatitis or autoeczematization. What is it? It is a disseminated secondary eczema. That means if you have tinea pedis, you can develop eczematous rash elsewhere, distant from the site of the fungal infection. So why it happens? It's probably an immune response due to the circulating infecting agents and also cytokines. So if a fungal infection like tinea pedis or carrion, it's called, and if you develop an EAD reaction, this termed as dermatophytid. A bacterial wound infection or thermal burn is termed as bacterid. Viral infection that can be associated with EAD reaction, such as molluscum contagiosum, and arthropods like scabies and lice is termed as pediculate. So the reaction can be eczematous. It can affect almost anywhere, like the forearm, leg, thigh, trunk, common sites, and it can present as either blisters, vesicle, urticaria, discoid eczema, follicular papules, morbilliform eruption, targetoid lesions, vesicles, and hand dermatitis. Non-eczematous EAD reaction is also common, such as psoriasis, erythema nodosum, those are painful nodules. Acute febrile neutrophilic dermatosis is also subcutaneous nodules, but associated with fever and neutrophilia and blistering skin conditions. So if you take a look at some of these pictures, this is an EAD reaction. It looks like allergic contact dermatitis, maybe even mistaken for eczema. These are also an EAD reaction due to an infection somewhere else. They develop papules over the knees. And this is a typical EAD reaction. See, ill-defined erythema, erythematous, dry, ill-defined erythematous plaque over the dorsum of the hand. Looks like a typical eczema. And this looks like could be a drug reaction or could even be eczema. This is also an EAD reaction secondary to an infection somewhere else. So if you look at this picture, take for example tinea pedis, whether it's interdigitalis or moccasin or tinea angum, tinea pluris or tinea angum. So they can develop EAD reactions that look like eczematous rash, papular and eczematous EAD reaction, or dyshydrotic eczema like EAD reaction. Dyshydrotic is vesicles that develop over the distal aspect of the fingers or toes. So the dermatophytosis it develops on another part of the body, distant from the fungal infection. And if you were to take a skin scraping on the EAD reaction, you won't find any fungal elements. If you treat the tinea pedis or if you treat the fungal infection adequately, the EAD reaction, the eczema, should subside. Okay, next up, tinea cruris. Cruris in Latin means of the leg. So it is a dermatophytosis of the groin, pubic region, perineal, and perianal region. So these are the common organisms. Tinea cruris, so typical configurate erythematous angry border, well demarcated plaques affecting the groin. And I just want to share some differential diagnosis. Like in this is an elderly patient with a rash over the pubic area, remained asymptomatic for 5 years, presented with low backache for 5 months duration. And the skin biopsy showed that it is infiltrating the epidermis and dermis, which is not typical of a fungal infection, not typical of a dermatophytosis causing tinea cruris. And the scans reveal that there are lymph nodes and skeletal metastasis. If you come across a case like this, if you're treating for tinea cruris for many months to years, what could your differential diagnosis be? Is it really tinea pluris, or is it eczema that after scratching, it has become very thickened, lichenification has developed? But if you get a skin biopsy like this, then you need to consider primary extramammary Pecos disease. You may have heard of Pecos disease. It's a ductal carcinoma of the breast or areola, but the extramammary ones can affect the skin. So this is actually a cutaneous adenocarcinoma. It's an intraepithelial adenocarcinoma, termed as primary extramammary Pecos disease. If it's secondary, that means it is arising from an organ inside, maybe prostate CA or uroepithelial CA or adenocarcinoma that has spread to the skin. So that is secondary extramammary Pecos disease. Could also present like this. So you need a skin biopsy. Okay, so that is some differential diagnosis. Tinea menum, it's quite easy to diagnose, but some other differential diagnosis you might want to consider is hand-feet eczema or contact dermatitis. So you get a well-demarcated scaly hyperkeratosis in the patches confined to the palmar creases and the fissures of the hand. So it's very well demarcated. Commonly is unilateral involvement. Unless you get 2 feet, 1 hand syndrome, where both feet are affected due to Trichophyton rubrum. So there's tinea pedis, and only one palm is affected. Scaling involving the right hand is accentuated in the creases. Tinea nigra is due to a mole, Hortea wernicki. It's quite common in tropical regions and quite common in patients with hyperhidrosis. So it's usually unilateral, asymmetrical. It's slightly scaly, and but it's not itch-sting. So this is other pictures of tinea nigra. Is usually asymptomatic, presents like a macule, and with advancing borders. It's frequently misdiagnosed as atrial lentiginous melanoma. This is atrial lentiginous melanoma. See, the borders are more irregular, and then it's more elevated. And if you can see there's a bit of color variation, which would be more clearer if you use a dermoscope to identify other features of melanoma. So how do you treat tinea nigra? Usually topicals would be sufficient. You can use Whitfield ointment, which is a combination of benzoic acid or salicylic acid, topical antifungal cream for 2 to 4 weeks. Next up is tinea capitis. These are the types of tinea capitis. The gray patch and the black dot are non-inflammatory. The carrion and favors are inflammatory. So I'll go through one by one. So this is the non-inflammatory, usually affects children 3 to 7 years old or immunocompromised adults. So the risk factors is contact with animals. Typical, they have household pets like cats, household crowding, lower socioeconomic group, warm, humid environments. So the gray patch can leave an alopecia, and the black dot usually affects the hair follicles. The hair becomes very brittle and falls off. You can see the black dots. So how it affects when the Trichophyton, it invades and keratinizes the stratum corneum of the scalp, the fungus will grow downward into the hair follicle and it will penetrate the hair cuticle. So you can either present as, in fact, as ectotrix, where the fungal spores are outside the hair follicle, or endotrix, where the fungal spores are inside the hair follicle, or favus, where you get all this hyphae inside the hair follicle. So this is the gray patch, the non-inflammatory tinea capitis. Ectotrix. This is endotrix, where it's also non-inflammatory, but the fungal spores are within the inside the hair shaft, and you get this black dot ringworm, all these black dots. The hair breaks off very easily. This is favus. It's inflammatory. You get this, what is termed as scutula, which is cups of crusting, yellow-colored crusting. It contains epithelial cells and fungal cells. So this is inflammatory tinea capitis or flavus, where what has happened, the hair has become matted, and then scutula around the base of the hair. If you have a wood slime, then you can see this grayish green to yellowish fluorescence. And this is carrion. Carrion is a severe inflammatory reaction due to a delayed immune response. So it's painful, it's erythematous, boggy, it's alopecia, and there are scattered pustules, typically of zoophilic species. This can result in permanent alopecia. Next is tinea facialis. This is tinea of the face, well-circumscribed annular, well-circumscribed pink to red macules or plaque, also annular, elevated border with central regression. And tinea barbae is typically due to zoophilic tinea like varicose and tagophytes. Risk factors are like for farmers if they come into direct contact with infected animals, and it can also be associated with heat reaction similar to tinea pedis. So this is tinea barbae, might be mistaken for folliculitis. Folliculitis barbae, which is due to a bacterial infection. So you get these red lumpy areas of pustules crusting around the hair. The hair can be pulled out easily. It's not excessively itchy or painful. This is quite very extensive tinea barbae. So our lab diagnosis, normally we take a skin scraping. We can send it for fungal CNS to the lab, or if you have a microscope, then you can visualize under the microscope using KOH stain. So this is hyphae, and this is hyphae with the fungal spores growing. So these are culture mediums that we use. So this is if you have this microscope, some of our hospitals have this microscope and this preparation to stain the dermatophytes. So this is how skin scraping is done. Use a number 15 scalpel, scrape all the scales, and then place it in this container, and then add 40% KOH and examine under the microscope, and you get you might see this septated hyphae. So what about the management? So if your topical antifungals are not helpful, before that, when you apply the instructions to apply a topical antifungal twice a day, optimally for 4 weeks, and then plus an additional 1 to 2 weeks after the lesion is cleared, make sure they apply on the lesion and at least 3 centimeters beyond the advancing lesion. So typical topical antifungals we commonly use, clotrimazole, miconazole, and even terbinafine. So if the lesions are too extensive, not responding to topical, or if you're dealing with tinea capitis or Mocassin tinea pedis, you need to go for systemic antifungal. So I've shared this slide. You can take a picture if you like. Now, this is the dermatology reference for treatment of tinea corporis, cruris, and facialis. It may differ slightly with our national antibiotic guideline in terms of duration and dose. So tinea corporis, my first choice would be itraconazole, recommended 200 milligram daily for 1 week. Children 3 to 5 milligram per kg per day, also for 1 week. My second choice would be terbinafine. Terbinafine is 250 daily for 1 week. So these are the adjustment for pediatric. So it's approved for children above the age of 4, and for griseofulvin, it's approved for children above the age of 2. So the others are also an option, but this would be the first choice: itraconazole and terbinafine. So you just pay attention to this dose and this duration, and then you can compare with our Malaysian antibiotic guideline 2019. So our MOH guideline recommends same dose but for 2 weeks instead. So sometimes I do give for 2 weeks if the tinea corporis, cruris or fascia is very extensive, or if it's recurrent. And then the terbinafine is also recommended as 2 weeks. The dosage is the same but for 2 weeks. So alternatively, fluconazole or griseofulvin also can be used. And while you're giving systemic treatment, you can continue the topical antifungal cream as well. It mentions that continue until clearance with the additional 2 weeks. So be caution if patient has renal hepatic impairment. And it's also mentioned that terbinafine clearance significantly reduced in patients with renal impairment. And topical nystatin is not an option for dermatophytosis. And then tinea pedis and meninum. So the option first choice would be itraconazole. So the dosage becomes BD, 200 BD for 1 week, or 200 milligram daily for 2 weeks. Alternatively, terbinafine, 250 milligram daily for 2 weeks. Okay, so you just pay attention to this itraconazole and terbinafine dose, and then you compare with our MOH. You want to take a picture? Go ahead. Then you compare with our MOH guideline. So it is recommended slightly longer, 200 milligram daily instead of 2 weeks, 2 to 4 weeks, or terbinafine also 2 to 4 weeks. Dosage is the same. So the topical antifungals can be continued as usual. You can also add on topical keratolytic agents if you wish. And if you're dealing with tinea pedis with maceration and potassium permanganate dilution, soak to dry up those the maceration. And capitis and barbae. So capitis, first choice or barbae can be first choice would be griseofulvin. So griseofulvin, the dose is increased to For children, 20 to 25 milligram per kg per day, microsize suspension, 6 to 8 weeks. Our guidelines mentions a bit longer, up to 6 to 12 weeks. For adults, 500 to 1000 milligram daily is the dose, 10 to 15 milligram per kg for 6 to 8 weeks, unless you're using ultra microsize, which is 750 milligram per day. So this will be the first choice. And then if you were to compare, these are the other options. So we compare to our MOH guideline. Risovalvin, similar dose, but slightly longer duration, or terbinafine, same dose, but the duration will depend on the type of dermatophyte. Microsporum, you need to give at least 8 to 12 weeks. Itraconazole is another option. And then you can also continue your shampoo, 2.5 selenium sulfide or ketoconazole shampoo. So for carrion, risovalvin should be considered first line, unless Trichophyton has been cultured. Surgical excision is to be avoided. Topical therapy alone is not recommended. And consider adding oral prednisolone to reduce inflammation in selected cases. Okay, next up is pityriasis versicolor. So this is a common fungal infection in the skin caused by dimorphic lipophilic yeast. So these are the common organisms. So Malassezia yeast is a normal skin microbiota and is common in adolescent and young adults, and quite common in hot, humid climates. So these are the clinical features. You get macule sharply marginated, round, oval shape, varying in size and with fine scaling. So typical distribution is the upper trunk, sweat-prone areas like the chest, upper trunk, arms. So in untanned skin, the lesion tends to be a bit light brown. In tanned skin, the lesion tends to be whitish. Dark skin, lesion tends to be dark brown macules. So versicolor means a variety of colors. So if you have wood slam, then it would fluoresce blue-green in color. And you can even do a tape test if you have a microscope in the clinic. It will give this spaghetti meatball appearance, which is the filamentous hyphae and yeast form. So these are the topical agents that we can use for pityriasis versicolor. Just show you this chart instead. So all the topical agents, such as antifungal shampoo, ketoconazole shampoo, zinc piriton shampoo, cyclopyroxolamine shampoo. These are some of the options you can use. And you need to, when you apply the shampoo, explain to the patient, you need to leave it for about 15 minutes before rinsing. I usually ask the patient to use it daily for 1 week, and then after that you can use 2-3 times a week. And then if you're going to give systemic antifungal due to poor response to topical, options are 200 milligram fluconazole 7 days or itraconazole 200 milligram daily for 7 days. So pregnancy, what can you give, what can you not give? Pregnancy category C, that means teratogenic effects have been documented in animal studies, but insufficient in human studies. So these all fall under category C, ketoconazole, selenium sulfide. But having said that, if a patient who is pregnant presents with tinea corporis and in the 2nd or 3rd trimester and not responding to topical antifungal creams like clotrimazole or miconazole, sometimes case-to-case basis, we do give ketoconazole shampoo because it's already in the 2nd or 3rd trimester. So we advise the patients that the risk of teratogenicity is less likely. Oral itraconazole is a definite no-no. Sorry for the misspelling. Not formally assigned miconazole, but falls under the same category as clotrimazole. It's just that it's not formally assigned. Oral fluconazole, definitely not. Topical clotrimazole is preferred in pregnancy. Topical and oral terbinafine is also in category B, but it's preferred that it be started after completion of pregnancy. Cyclopyrox is also category B. If you're going to give an antihistamine, then loratadine is the most studied antihistamine in pregnancy. Both are secreted in breast milk, loratadine and cetirizine, but loratadine is preferred over cetirizine because of lesser secretion in breast milk. So itraconazole, a lot of drugs interact with itraconazole. So if they're on statin, you have to be careful because itraconazole is an enzyme inhibitor, so it can enhance the effects of other drugs. So it can enhance the effects of simvastatin or atorvastatin. So if you're going to give itraconazole, what I normally do, I ask the patient to stop the statin for 2 weeks while on itraconazole. Rosuvastatin doesn't seem to have any interaction with itraconazole. And then, but having said that, patients with HIV, they are on Bactrim, they're on heart therapy, so those drugs will interact with with itraconazole or fluconazole. So, but if they have esophageal candidiasis or oral candidiasis, we still give, despite the adverse drug-to-drug interaction. So other considerations like heart failure, liver toxicity, prolonged QT, acrohydria, cystic fibrosis, renal dysfunction, immunodeficiency are some of the disease interactions associated with itraconazole. So please be cautious when patients have these kind of conditions. And itraconazole is best taken with food increases the absorption of itraconazole capsules, but decreases the absorption of itraconazole solution. That's why we say sometimes we ask the patient to take a cola beverage to help lower the gastric pH and improve the absorption of itraconazole. The candidiasis, typical organism Candida albicans, typical site, skin, mucous membrane. Cutaneous candidiasis occurs in moist occluded skin areas. So these are the risk factors: diabetes, obesity, hyperhidrosis, heat, maceration, systemic steroids, chronic debilitation. And these are the typical sites, usually in the flexural sites. So you get erythema with pustules. You get these satellite pustules. The advancing infected border usually stops when it reaches the dry skin. So inframammary axilla, groin, perineum, intergluteal cleft are the common areas. So if you're not sure whether it's tinea corporis, try to look for pustules. They might be present. It's also very sharply demarcated. It can be polycyclic like tinea corporis. So if you're doing an investigation, this is how the skin scraping, the fungal spores look like. Pseudo-hyphae are seen. These are all hyphae. And these are the treatment for candidiasis. You can opt for candidiasis. Fluconazole is slightly better than itraconazole in terms of response. So you can opt for fluconazole or itraconazole. And then the topical creams are the common ones that we usually use, Simico or clotrimazole. Candida intertrigobalanitis, you need to give itraconazole or fluconazole slightly longer, up to 2 weeks. Okay, it's either fluconazole 100 daily for 2 weeks, or 150 mg weekly for 2 to 4 weeks, or itraconazole 200 mg twice a day for 2 weeks. Same goes for Candida vulvovaginitis. I've just included 2 pictures here. This is cutaneous candidiasis. This is Candida vulvovaginitis. So the dose would be either fluconazole 150 mg step dose, or in severe disease, you can give 3 doses at 3-day intervals. Nystatin 100,000 units vaginal suppository daily for 14 days. Clotrimazole, this is a dermatology reference 1% vaginal cream daily, but BD application is acceptable for 1 to 2 weeks. Vaginal suppositories 100 mg daily, 7 days, or 200 mg daily for 3 days. Miconazole, this is the same as clotrimazole. You can give BD instead of daily. Okay, so this is a typical napkin dermatitis, also due to candidiasis, which you might see in infants. But this isn't. This is a different condition called granuloma glutealis infantum. This is due to infants that develop irritant contact dermatitis due to diarrhea or encopresis, soiling, fecal soiling. It can even occur in adults due to urinary incontinence. So you do get some satellite pustules, but this is not due to candidiasis. So you get coalescing moist pink papules. Okay, so need to. Okay, next one is onychomycosis. This is due to either dermatophytes or non-dermatophytes like molds and yeast. It's a term used to encompass all fungal nail infections. So these are the typical fungal nail infections. You have 3 patterns: distal, lateral, proximal, subungual, and superficial white. Okay, and then you can even have a mix of any of these patterns. Additional patterns are your total dystrophic onychomycosis, which is a sequelae to onychomycosis, and endonyx, which is actually an infection, fungal nail infection. Fungal infection of the nail bed, which is nail bed is underneath the skin. I'll show you some pictures. So this is distal lateral. You can see that the destruction, the subungual hyperkeratosis, the yellowish, there are crumbling and the thickening of the fingernails. So the point of invasion is via hyponychium. And this is proximal subungual, where the invasion is at the proximal nail fold. Superficial white is very difficult to treat, and direct penetration into the dorsal surface of the nail plate. And this is endonyx. It primarily affects the nail bed. Over this area is the nail underneath the skin. So you get this milky white discoloration in the nail plate. And this particular type of onychomycosis usually does not have subungual hyperkeratosis or onycholysis. So some nail terms, onychosis, which is thickening or hypertrophy of the nail plate due to subungual scale, subungual hyperkeratosis, which is scaling under the nail. The scaling is so thick it lifts the nail up. Jagged crumbling, discoloration of the nail, rigid crumbling, scaling on the plantar skin web spaces, and onychoma or dermatophytoma, which is a thick localized area of infection of the nail plate. I'll show you a picture shortly. But before that, when you're dealing with this is total nail dystrophic onychomycosis, where you can see the nails are very dystrophic and brittle and discolored. This is different. This is tracheonychia, which is 20 nail dystrophy. The nails are thin, opaque, and the nail plate gives the impression of sandpapered, and you can see all this longitudinal ridging. This is can be associated with alopecia areata, lichen planus, eczema, or psoriasis. This can even occur in children. So you need to investigate along these lines, treat the underlying cause, either with steroids for alopecia areata or retinoids for psoriasis. And this is a JAK inhibitor, which is also an indication for this 20 nail dystrophy. So these are some of the non-dermatophyte onychomycosis with the typical presentation, Fusarium, aspergillus. If you ever seen patients with those black color nails, that one is due to aspergillus niger. So each non-dermatophyte has their particular key features and pattern. And then Candida onychomycosis also has a typical presentation. There are 4 types of presentations, like chronic paronychia, distal nail infection, chronic mucocutaneous candidiasis, or secondary candidiasis. So chronic candidal paronychia starts with near the nail fold, near the cuticle. This is the cuticle. The nail fold is swollen and red, and it's lifted off the nail plate. So you can get these white, yellowish, greenish marks appear on the nearby nail. The nail may lift off the bed, and it becomes very tender when you press it. So these are some differential diagnosis. Staphylococcal paronychia, we can see an abscess has already formed. This is herpetic whitlow, the herpes simplex virus. So some of the indicators of poor response. So this is dermatophytoma, which I mentioned earlier. It's a mass of fungal organic debris enclosed within the nail plate, above nail plate above and nail bed below. Appears like a patch of xanthonychia. So nail factors that imply poor response: very thick subungual hyperkeratosis, lateral involvement, dermatophytoma, more than 50% of involvement on the nail bed, slow nail growth, total dystrophy, matrix involvement, patients immunosuppressed, peripheral arterial disease due to poor circulation, and poorly controlled diabetes mellitus. It's always important to control the diabetes. So these are the investigations we send, like nail clipping, fungal CNS, to get the specificity of the causative fungus. So treatment, onychomycosis. This is topical FDA cure rates. So the cure rates are in green. Cure rates are only about 6 to 10% with topical, tavobarol, cycloporox, 15 to 20% with efinaconazole, 10%. But the cure rates are much higher with systemic antifungal, such as terbinafine, itraconazole, fluconazole. So I will show you the chart of the treatment chart shortly. You can take a picture if you like. Recurrent disease is common with toenail infection when the degree of involvement is very severe, 20-25% relapse. So you need to have some preventive measures like breathable footwear and socks, antifungal, absorbent powders, proper nail clipping, avoid re-exposure, like not going barefoot into the locker room. And old shoes often harbor a large number of infectious organisms. It should be discarded or changed or treated with disinfectants or antifungal powder. So you can take a picture of this chart. So this is the dermatology, Bologna. Sorry about this one. So this is the Bologna. This is our MOH. So you can see for toenail and fingernail involvement. So if you're going to give itraconazole, maybe some of you are quite familiar with the 200 milligram BD pulse once a week per month, either 3 or 4 pulses if toe and fingernail affected. If only the fingernail, then maybe 2 pulses, 200 milligram BD, 1 week a month. Alternatively, you can give 200 milligram daily for 12 weeks for toe fingernail infection, or 6 weeks for fingernail infection. So it doesn't differ much with our MOH guideline. So yeah, so pulse itraconazole also 1 week per month is the preferred choice. So if you're, and you can also give the other topicals, like amorphine, 5% nail lacquer, once or 2 times a week. You can give up to 6 months for fingernails, 12 months for toenails. So please take a picture of this and then you can use it as a reference. Other options, or if itraconazole is contraindicated, you can also, other options would be terbinafine. Terbinafine is a daily dose, 12 weeks for finger and toenail infection, and 6 weeks for fingernail infection. So it doesn't differ much with our MOH. Please take a picture and you can compare and use this as your reference. Okay, so other non-pharmacological treatments are, which I don't particularly use because of I don't have the modality: infrared laser, PDT, magnetophoresis, and ultrasound. Okay, PIDRA. So PIDRA is PIDRA is a fungal hair infection. It's usually asymptomatic. It's either it's known as trichomycosis nodularis. It's the black PIDRA and white PIDRA. Black PIDRA is caused by PIDRA horte. White PIDRA is caused by Trichosporon species. So you can see PIDRA means stone in Spanish. Why we say stone is because you can see this concretion here. Means there's a bit of solidifying here in the hair follicle, in the hair shaft. So, and it looks like a concretion on the hair shaft. So you have white PIDRA and you have black PIDRA. So white PIDRA can also infect animals. This is one of the species. And black PIDRA is caused by horte. So this is a magnification of white and black PIDRA. So it might give you an impression of head lice. So just to compare, this is head lice, pediculosis, head lice with nits, and this is the head louse. So it's a different condition and different treatment. For head lice, you have to give permethrin 1%. Permethrin 5% is for scabies. Permethrin 1% is for pediculosis. So after you shampoo your hair, apply permethrin and then leave it for 10 minutes before rinsing. Repeat after 10 days. So these are the treatment for PIDRA. You can give topical antifungals like the miconazole, clotrimazole, cycloperoxylamine, selenium sulfide shampoo, castellanipane, magnesium zinc, chlorhexidine, ketoconazole, iconazole, miconazole cream, topical amphotericin B, or topical keratolytic 30% SC solution. Or if the PIDRA is very extensive, then you can go for systemic treatment like for itraconazole 100 milligram daily for 8 weeks. Is an option for white PIDRA. These studies are not very thoroughly researched. It's mainly anecdotal. That means it has been tried in a few subjects and appears to be effective. So itraconazole 100 daily for 8 weeks, or black PIDRA, terbinafine 250 milligram daily for 6 weeks. If you're interested, you can go through the research by these authors. Okay, last one, subcutaneous mycosis. This is a very large topic. So I'm only going to talk about sporotrichosis because this is what we commonly come across in our practice. So it's due to Sporotrix schenki, which is the typical fungus that causes sporotrichosis. So most common clinical presentation is lymphocutaneous, otherwise known as the sporotrichoid pattern. So it will, in fact, you get a cat scratch, cat bite, and it causes a localized reaction, and then it can spread through your lymphatics in a nodular pattern. So direct inoculation by rose thorn, sometimes it's called rose thorn disease, or direct inoculation by cat claw, bite, scratch, minor penetrating injury by injury or implants the fungi into the dermis and subcutaneous layer. So in Malaysia, the commonest preceding injury for sporotrichosis is cat scratch. A gardener being prickled by contaminated rose is a classic mini acquisition of sporotrichosis. Okay, gardener's disease. So this is the most common presentation, lymphocutaneous, where the lymphatics are also affected. So you get a bite maybe on your wrist. This might be the primary inoculation site, and then it spreads through the lymphatics in a nodular pattern. This is called sporotrichoid or lymphocutaneous sporotrichosis. Okay, now sporotrichoid is not limited to just sporotrichosis. The lymphocutaneous spread is also seen in atypical mycobacterium, like Mycobacterium marinum, then a few unusual ones like nocardiasis, pyogenic bacteria, and then one more I wanted to mention is cat scratch disease. Cat scratch disease is not due to fungus, it's due to bacteria, Bartonella henselae. So it can also present in a sporotrichoid pattern. So these are the second type is a fixed cutaneous type. That means the cat scratches or bites at one area, and you get a localized ulcer or plaque without any lymphangitis. And the third type is disseminated sporotrichosis. So this is quite common in patients who are immunocompromised with HIV, diabetes, pathological malignancy, chronic alcoholism, or long-term immunosuppressive therapy. So investigations, typically we have to do a skin biopsy. These are all the things that we send. We send fungal PCR, fungal CNS. Quite often it comes back as granulomatous inflammation. So that is suggestive of a fungal infection. And differential diagnosis also we send, like atypical mycobacterium. We also send these investigations. And routine blood tests, because you're going to put the patient on itraconazole for long term, for a couple of months. So you want to know how the liver is. So this is the dose. We give typically 200 milligram daily or 100 milligram daily. Sometimes we give PD for extensive lesions. And once the lesion is cleared, we give for additional 1 month. Okay, so these are some older medicines that has been used, but not used of late because of typical side effects. Amphotericin B is mainly for very severe disseminated disease. Okay, so I think I've come to the end of my presentation. 50 minutes. Okay, so we have 10 minutes for Q&A. Okay, thank you.
Thank you, Doctor. We have actually a question from the floor. Let's kickstart the Q&A, yeah, Doctor? Okay, the first question is, how long usually treatment for fungi using topical agent, in which in a condition we use combination topical antifungal, topical antifungal as well as steroid. So that means is how long is the treatment?
Okay. So some fungal creams already come in combination with Candid B. So if the lesions are very inflammatory, very red, you can give a combination of antifungal with steroid. But once the lesions are already improved, you have to see the patient back within a week or two. Once it's already improving, you need to remove or taper off the steroid. Don't continue steroid for too long. Just maintain with the antifungal. Tell the patient to apply on the rash and surrounding area at least 3 cm so that it doesn't peripherally expand. And then continue for additional 2 weeks after the lesion has resolved. So sometimes I do give Fungicort. Fungicort is with mild steroid hydrocortisone. Candid B, sometimes I seldom give Candid B. If I were to give an antifungal, I'll give with a mild steroid hydrocortisone. If I don't have a combination preparation, I give it separately, clotrimazole and iconazole plus hydrocortisone. But I very seldom give topical steroids in a typical tinea infection, unless it's very, very inflamed, very erythematous.
Okay, second question. Candidiasis infections, precisely symptom of itchiness. Is it always advisable to add steroid into antifungal infection?
Okay, so this will be quite similar to the first question.
Yes.
If it's very inflammatory, very erythematous, very pruritic, then yes, you can add a mild steroid to the antifungal preparation. But see the patient back earlier, within 1 or 2 weeks, and then slowly taper off the steroid. Just continue with the antifungal therapy. Okay, if it's difficult to treat and it's recurrent, then you can always opt for systemic or the vaginal suppositories.
Okay. All right. Third question. This is a follow-up question from the earlier question. For vulvar vaginas candidiasis, what was the dose for fluconazole 150 mg? Is it daily or BD? I think you have a slide for that just now.
Can take a picture. Can you see the slides?
No, you have to share screen.
Okay, so this is cutaneous candidiasis. Cutaneous candidiasis. This is vulvovaginitis. Okay, so I put two pictures here: cutaneous candidiasis and vulvovaginitis. So if it's cutaneous candidiasis, you can just give fluconazole 50-100 milligram daily for 2 weeks, or 150 milligram weekly, also for about 2 to 4 weeks. Fluconazole responds better for candidiasis. Second option would be itraconazole. But for vulvovaginitis, the fluconazole would be, you can take a picture, 150 milligram stat dose, or very severe, 3 doses at 3-day intervals. Yeah. All right, so the next question is, what is your expert opinion for frequent vaginal fungal infection? Okay, so whether it's really fungal infection, whether it's concomitant bacterial infection. So my opinion is that co-manage with gynae, get them to do a vaginal swab, see whether there's any other bacteria involved. Sometimes you might need to give a course of antibiotic as well on top of the antifungal therapy. Which case would you use griseofulvin compared to antifungals? Griseofulvin I typically would use for tinea capitis and tinea barbae compared to the other antifungals. If for tinea corporis, cruris, officialis, if somehow itraconazole or terbinafine is somehow contraindicated, then that griseofulvin would be my other choice. Is it safe to use antifungal powder for a long period of time? Will it develop resistance? You should not use for a long period of time. You should use you should review the patient within 2 to 4 weeks, see whether it is helpful or not. If not, then you need to treat systematically with a systemic antifungal.
Okay, doctor, let me take over. Sorry, I'm back. So the line was disconnected. Which case would you use griseofulvin compared to other antifungals?
Well, it just came back online.
Yeah, it just came back.
Okay. So I thought I was talking just now. All right. Which case would you use griseofulvin compared to other? So griseofulvin I would use for tinea capitis and tinea barbae. For other dermatophyte infections, if itraconazole or terbinafine is contraindicated, then I would probably use griseofulvin. Griseofulvin for tinea capitis for children, just remember the dose is on the higher side, between 20 to 25 milligram per kg. And then there's also the ultra micro-sized griseofulvin for adults. That one, the dose is a bit lower. Is it safe to? Yeah.
Okay, what would be the treatment like for spororitis and other lifestyle modification, spororitis, and most effective management in GP settings?
Treatment like for psoriasis and other lifestyle modification. Okay. So psoriasis in the GP setting, you want to screen the patient for metabolic diseases like diabetes, hypertension, dyslipidemia, obesity, or simply being overweight, very big waist circumference. So these are the things that you can screen in a GP setting, because these associated factors can contribute to psoriasis. So you can develop metabolic syndrome first and then psoriasis, or you can develop psoriasis and later on develop metabolic syndrome. So in psoriasis, they respond to topical steroids. But if you find you're giving very potent topical steroids, then the area of involvement is very extensive, very wide. The body surface area is more than 30%, and these patients need to be on systemic therapy already. In Malaysia, more than 30% is considered severe, but in British guidelines, very severe is already more than 10%. Body surface area. Body surface area is like your one palm is considered 1%. So it's like eyeballing what is the extent of psoriasis involvement on the body, hands and legs, scalp, face. what was the other? Most effective management? Yeah. So lifestyle modification would be things that can contribute to metabolic syndrome, things that can contribute to diabetes, to high blood pressure, to hyperlipidemia, and the diet. I think you left out question 6.
Is it safe to use antifungal powder for a long period of time with the patient develop resistance?
Antifungal powder is not meant to be given for a long period of time. I will give for maybe 2 to 4 weeks and then see the patient back again. If the patient is not responding, then I will give a systemic antifungal. But if you're dealing with tinea pedis like mocassin or interdigital maceration, sometimes I just start the systemic antifungal plus antifungal powder or antifungal cream.
Okay, I think that is the last question, right? Okay, any more questions from the floor?
I'm sorry, if I was too fast. I tried to cover as much fungal infections that you can probably come across in general practice. So I hope all the pictures and diagrams help.
Yeah, it is a very solid and very comprehensive presentations of skin's fungal infections. Yeah. All right, I think we can wrap up now since no other questions. So thank you for all the participants. We have nearly 300 packs on the screen. So thank you, Dr. Irshath, for spending time with us today, and also your very solid presentation as usual. All right. So without much, so thank you, and we shall meet again in the near future for another topic, another speakers. So I thank you from us at KMI Taman Desa Medical Center. Thank you very much. Thank you, Doctor.
Thank you. Bye.